everyone. Welcome back to another Research Works episode.
Hello, Marissa. It's good to have you back on the couch again, talking on the pod. I feel like whenever we see each other, there's like this tiny likelihood you'll become unhinged very quickly.
No, we're focused. We're focused people. We've had our moment. Now we're in the icebreaker question. We can have a moment or two. And
I think so. We're very focused today.
We
very
will be.
focused because we have a very great topic to talk about. Very fun guest to have on the show today.
I'm very excited. So today we will be talking about an article published in Developmental Medicine and Child Neurology in December 2025 titled Time Toxicity and Shared Decision Making in Cerebral Palsy. And we have the lead author here today. Welcome, Dr. David Frumberg.
Welcome.
What's up? What's up? How you guys doing?
Very, very good.
What's it like in the future? My kids want to know what's going on in the future.
Look, the future's bright. We're still here. And
literally bright.
It's literally bright, yes.
It was fresh this morning.
It was
sun
very
is up
fresh
there.
this morning, yes. It is autumn or fall for us now and getting a little bit cold. But cold for us is probably a bit different to your cold, hey? Probably, yeah.
Yeah, we hit negative like 18.
Yeah, we don't do negative.
Okay, we had 9 degrees Celsius here this morning and we thought it was cold. So.
Oh, yeah.
I saw a little bit of fog in the distance and I was like, ooh, what's that? No, the future is good. Let your kids know the future is still bright and it's still good. So, yes, it's always a bit weird speaking to people 12 hours behind us, isn't it?
But we appreciate you staying up to do this, David, so thank you.
We really do. So we have had the chance to speak with you before when we talked on your co-authorship in this paper that we talked about DMI and CME, where's the evidence? That was a fun conversation. Lots of us on the chat, but this time we just get you one-on-one, which will be really fun.
Yeah, very excited to have you, David. And so some people might know a bit about you from before, but I will just do a formal introduction of you before we jump in.
It's an impressive one, so stay tuned. Here we go.
Yeah. Dr. David Frumberg is an Associate Professor of Orthopaedics and Rehabilitation at the Yale School of Medicine, specialising in complex limb reconstruction, limb lengthening and paediatric orthopaedics. He directs the Yale Limb Restoration and Lengthening Program and the Cerebral Palsy Program at Yale New Haven Hospital. Dr. Frumberg is known for his work in complex congenital, developmental and trauma-related orthopaedic conditions in both children and adults. He is an expert in limb lengthening surgeries, gait analysis and cutting-edge minimally invasive techniques. His research emphasises the lifelong care and effects of ageing on neurodevelopmental disorders, striving to maintain the highest quality of life and mobility for his patients across their lifespan.
I mean, honestly, mind blown. How do you even, I don't even get what you do. How do you do that?
It's definitely a combination of odd niches, you know? Like most people go into orthopedics to be a team doctor or replace joints or something, but it's sort of like a different path, I would say.
Yeah.
It's a lot of fun to do things that are kind of new and different. And what's cool is you may say, oh man, limb reconstruction, neurodevelopmental and neuromuscular disorders, what is the combination? But actually they sort of feed each other very nicely. You know, you can use really complicated limb reconstruction techniques to take care of adults with contractures and all these various things. So it's pretty cool. It's a lot of fun.
Yeah.
But, you know,
wow.
I don't know. I get to meet cool people from Australia from the future. So
well, we think what you do is amazing.
Very cool.
But as usual, we have an icebreaker question. I'm excited for your answer. No pressure. What is a line from a movie or TV show that comes up most in your daily life? It can be a favourite line or something that pops in your head.
Yeah. Should we go guess first? Are you ready to go,
David? You knew I was coming. All I do is quote movies all day long, like a good millennial. You know, like my residents and med students, they don't even watch movies. Like I remember we gathered a bunch of DVDs, my partner and I, because she also quotes movies, and I gave 10 DVDs to a resident and said, watch these by the end of the rotation. And they were like, what is this? What do I play this on? Yeah, what's a DVD? You don't have DVD? I have boxes of burned DVDs. Anyway, one I said today, so I usually am quoting the same movies, right? I use, what's some things I said today? A lot of Clueless.
Clueless?
You guys know that movie?
Yeah.
Like, that was way harsh, or I know what you're thinking. This is probably an Noxema commercial, all those ridiculous lines. But the one that comes up a lot is, you want a toe? I can get you a toe. I can get you a toe by 3 o'clock this afternoon. That's from Big Lebowski. With nail polish, Ed.
This is so good. This is really your jam. Do you have another one?
It feels like he's got
Tons.
some coming.
Yeah, you name a movie.
So good.
That's all we got.
I love that.
What are yours?
Okay.
Yeah, good luck.
Okay, all right.
Better not suck.
I know, you set the bar so high. Gosh, now I am second guessing mine. So I don't even remember the film properly, but every time someone just says, and this one time, I'm like, oh, at band camp?
Oh, yeah, we're good. Yeah.
Every time. And then every time there's some sort of conflict about something, I'm like, look to the cookie, Elaine, look to the cookie. I love it. A good Seinfeld reference. I can't help myself. So it usually relates to Seinfeld in some kind of matter. And it's usually, but at this one time at band camp comes up all the time. I'll be in a meeting and it's a proper Zoom meeting and you're meeting with like these world-renowned researchers. And then someone will just say, and this one time, and I'll sit there and I'll go, at band camp?
It's all these 90s.
I hope you maintain...
Thank you. I'll maintain my
I also said this morning, that the city is a toilet to someone because there was trash outside, as a good Seinfeld line.
I love that line. I love that.
Seinfeld is the best.
Seinfeld is the best. Yep.
Mine is also down at 90s trajectory. So Dumb and Dumber I constantly quote, but I won't go into that too much today.
One in a million.
One in a million.
Yeah.
But Cool Runnings was my favourite movie growing up. And there's that bit where they stand in front of the mirror and they're like, I see pride, I see power, I see it. And I keep going. But I always joke before I did a presentation or anything as a kid, or even if one of our colleagues has to do something, I'm like, come here. Okay, what do you say? I see pride, I see power. And yeah.
You should make your kids do that before their PT sessions.
I did.
Between our PT sessions.
I got them to do it once.
Oh,
and
obviously.
The other one is feeling Olympic today. And people don't really get it when I'm in the morning and I'm like, okay, I'm feeling very Olympic today. And they're like, this is the thing, unless you're born in our era.
It's a great movie. Yeah. It's a good one. Ed, there's a twinkle in your eye there. Do you want to join in on this one? You have a line, don't you?
Well, you guys are all millennials, so I'm the generation that came before yours.
I wish I was a Gen X, though, I have to say. I'd rather be Gen X.
Yeah, we built the modern world.
See, now he begins.
Yeah.
Okay.
So
you guys invented the DVD.
We are grateful.
So my favourite film is actually The Princess Bride. And I'm a Dutchman. You can't tell by the accent, but I carry myself like a Dutchman. So supreme confidence, bordering on arrogance just a little bit. But in the Princess Bride, Wally Shaw plays like the narcissistic criminal mastermind Vizzini. And so there's this battle of wits that happens over poison goblets. And Wesley asks Vizzini if he's a genius. And Vizzini boasts and says, let me put it this way. Have you ever heard of Plato, Aristotle, Socrates? Morons. That's my favourite line. And it's very Dutch.
It's a very good line. It comes up quite frequently for you, it seems, that line. Do you know that movie? Have you watched it?
I'm so sorry, I haven't watched it.
Oh my gosh, Princess Bride.
We have to stop the pod.
I'm just mailing the DVD to you.
Thank you. I will get it in a month.
I love it. Great icebreaker.
I coach my kids lacrosse, and whenever there's a big hit, I always yell out on the field, "You're dead, Mom."
Kiss my lucky egg. That's so good. I'm so glad that you also...
this is good.
Sanka,
so my challenge for all of us then is, as we go through this actual paper, whether you can insert a line in. Let's see if you can make it happen.
Well, then I'll get too distracted, so I'll
just try. Dropping them.
Okay.
Give it a go. All right, so let me give everyone a rundown about what we're going to be talking about. And it wasn't movie lines, although I feel like I could talk about that for a long time. Yeah.
It's great if someone skips that whole opening bit and then we're in the middle of the conversation and I just start calling people morons. It's going to be fantastic.
It is funny. I'm just going to give a call out to Ginny Paleg here. Ginny wrote to me once before I really knew her, and she said, just this whole bit at the beginning where this banter goes back and forth, it drives me nuts. Just get into it. And I was like, well, we like it. It's fun. And then later on, she wrote back and went, actually, it's my favorite bit. I love it so much. So there you go, Ginny. There we go. We persisted.
Ginny Paleg, more. Let's see if she's listening.
She's totally going to be writing back to you. Just stand by. Okay. Let me give you a rundown about this paper. Clinicians and families regularly use shared decision-making to establish goals and outcome measures. Seldom, if ever, is the critical question of time usage, or more specifically, time-related burdens accounted for. Time-related burdens are not included as an outcome measure in cerebral palsy research, something which may have profound effects about which we are unaware. This paper aimed to seek to apply the concept of time toxicity to people with disabilities who frequently use healthcare services.
This is so good because it's something I feel like we have conversations with families about all the time. But
all the time.
It's
You're
not,
right.
like you said, in research, it's not something that was included in our area at all.
No.
So going back to the very start, David, what inspired you to bring the oncology concept of time toxicity to our area in this world of cerebral palsy care?
Well, just what you said. Every single person since we published this paper who read it or who I've like force-fed it to, they all say the same thing. They're like, I've been thinking about this on some subconscious level for my entire career, right? Like you've thought about this.
Yeah.
Like, what are we even doing? Have you ever been in a really challenging case? Maybe people aren't seeing eye to eye. You're investing a lot of time. And selfishly, you say, like, what are we doing here? What is this working?
Yeah.
Is this worth it?
Mm-hmm.
Yeah. And then I think just we all go through this natural progression. You guys go into PT, your listeners go into other disciplines, and then you learn about F words and you learn about all these different ways we should be thinking with our patients. But it's all about like getting your patient to the best place. But it has nothing to do with how, if you were that family, what you would want for yourself. I don't know. I'm kind of like beating around the bush a little bit. It's basically like, would I want someone just telling me what I need to do if I'm not sure it's going to work? And are they sure it's worth the investment? So these are all questions that we ask.
Was there a specific patient or family member that really highlighted this to you that kind of got you like, I need to do something and put this together?
I honestly think it's just more of like a millennial thing. Don't waste my time kind of thing. Like, look how we all are now after the pandemic. It's like, don't waste my time. I'm not going to meetings. I'm not even coming to the office. Like, leave me alone. I'm not going to go buy a DVD player. This is crazy. So I think it was more that, I'm a surgeon. So in surgery, when we're looking at little kids, and we try to estimate like when is the best time to intervene.
Yeah.
So let's say some kids got, I don't know, like an equinus contracture, right? And so we're like, you got to do stretch casting or Botox or all this stuff. And the kid's like, dude, just I want this, or the kid's too young, but you say to yourself, man, I wish I could just nick this tendon and send them on their way. And it's no longer a problem that they have. They don't even have to see me for a while.
Yeah.
They don't have to see anyone for a while.
Yeah.
Like that's literally how it came about.
Wow.
Just why are we doing this whole thing because you're scared of the S word, which is surgery?
Yes.
When we could just like do surgery and move on, right?
Yeah. Yeah.
So I think that's where it deeply seeded into my head. And then I, as you mentioned, sort of by accident, stumbled upon that cancer paper talking about time toxicity. And then it was like, oh my God, this is incredible.
Yeah.
There's more to the story too. I don't want to go into it too much.
No,
I'm going to tell you the story though.
Tell us, yeah.
Briefly. So Nathan Rosenberg, one of the authors on the paper, is one of my best friends, like professionally. If he lived closer, he'd be one of my best friends personally too. He is one of my best friends personally. But he just lives far away. I'm going to visit him though. Okay, regardless, every AAC PDM meeting, which can be a little bit long if you don't have a lot of papers to present or something like that, we would like sneak away, just leave the meeting, go hiking. And when the meeting was in Anaheim, we picked one of the days and we went up to Joshua Tree. We were just hiking around, and I just like brought up this concept that I've been throwing around in my head, like time toxicity, like what, all this thing. And then, so Nathan, who is a lot more, I would say, eloquent with the way that he puts things into practice, he like blew my mind, threw it right back at me with, as a rehab physician, all the things that he thought could benefit from the framework.
Wow.
And I think the common thread is that we just don't know how much time anyone is spending on anything.
Yeah.
And even routine things like visits cause burdens that we're not sure of, or that we're not aware of, I should say.
Yeah.
So
that's a great story. I love that. I love how ideas formulate that way, like where you do think about it and you percolate about it, you talk about it with your colleagues, and then it makes a whole lot of sense. And sharing that concept just provides vocabulary. I think that's very Brene Brown, but it provides vocabulary to be able to understand what it is that you're seeing, what you're experiencing. I mean, it only takes a moment where, look, I had to go and get some blood tests and, I don't know, just a standard GP visit. And sometimes they go, oh, you need to do this now, you need to do this now. And so you've got to take time off work. I've got to drive there. I've got to sit in the waiting room. I've got to, the whole process of an appointment. And you only have to sit there yourself in an appointment to realize everything that it took to get to this place as well, and the impact that it has on your family or your colleagues. Like, it's time, right? It's a real finite resource. And you do talk about that in the paper. No one's discovered more than 24 hours as far as you're aware, David?
I mean, I'm in the future right now, so that's kind of cool. But aside from that,
yeah,
I'm pretty sure 24 hours is a universal thing for everyone.
And I think that's the whole point, isn't it?
Exactly. And I think it's not something we always discuss. Like you said, if someone has an appointment, how long have they travelled to get here? Has the parent had to take the whole day off work to get here? Have the other siblings?
And is it worth it?
Yep.
On the other side of it, is it worth it, right?
And the children that we're seeing in our care have, multiple specialties, multiple appointments, multiple therapies. And so, anyway, we'll go into this more.
Yes. So when you talk about oncology, David, the question I had about that is, obviously there was a lot around that time toxicity, around like survival time. That's everything, right? But when you contrast it in cerebral palsy, it's often not, we're not talking about the same concept in terms of survival, in terms of whether they're going to survive this treatment that they're going to have. How do you contrast that, and how do you put that into perspective for people when we're talking about time still?
I actually discussed this with a patient and his family, and the mom was like, what did she say? She called it like friendship survival, or like fun survival. She used some term that seemed way harsh to I, but aside from that, it was good. It was basically like, like I'm going to do all these things for my kid, but like I, as a mom, I can't even go hang out with my friends because I'm so busy shuttling this child all over the place, or even just being present. Kids hospitalized. That's all this time they're spent hospitalized. That's, like hospitalization in a kid who's hospitalized. Yeah, you got to be there for them. You're not planning on it. So then think about that as the new baseline. Okay, now I'm like missing out on all this other time. All this other time has to be spent. So you could go so many different ways with it. But in general, something that's very important to remember, some people, and we kind of touched on it in the paper, but we didn't really dive into it. There's a concept of disability identity, which we respect. So some people, it could be a bad thing. It could be an extremely good thing. Some people identify with their disability, and that could be pathologic or it could be very healthy, right?
Yes.
Like in either way.
Yes.
So some people actually really don't find the time they spend interacting with healthcare toxic. And so what you have to remember is that, like, this is not a universal thing.
Yes.
Like, nobody should go to physical therapy. It's such a waste of time. That is not what we're saying at all. What we're saying is that for some people, they thrive on it. I have adult patients who love interacting with the healthcare system. And I encourage them to continue doing so. It's the social framework they're in. But some people don't, or at least would like to explore the alternative. And I think the burden is on us to allow them to understand that.
Yeah.
The concept that got me more able to discern between like cancer, vascular conditions, and disability, or cerebral palsy, I should say, is like the F words, right?
Mm-hmm.
So if you look at it more of, all right, so it's such a waste of time to do stuff, or things are burdening your time. Like what does that mean? Well, they're taking away your time from being able to do F word things.
Yeah.
I think if you think of it that way, then it makes a lot of sense.
Yeah. Yeah.
Such a good thing even just to have conversations about, though, with time. Like, yeah, because it's something parents, if you offer something, they'll always often say yes and want to jump at it. But when we are having these discussions about time, and even the way families want to prioritize their time and the F words and all of these things, it makes us think, as whether it's yourself as an orthopedic surgeon, whether it's us as physios or physical therapists, you know, what we're recommending, the parent is very likely going to want to do because they want their absolute best for the child. But the onus of time, we really need to think about what we're recommending.
Well, it's a variable.
Whether it's an investigation, a therapy, a surgery, which I think we already do, because obviously we pride ourselves on evidence-based intervention. We don't want to do things unless it's going to be best for the child, but
that's what we hope to, right? But I think it's also very seasonal. So, you know, you might go through different seasons in life where it's that, you know, I think where I see it the most is the transition between early intervention and then going more into school age. And like they just can't keep up the dosage they normally keep up with in the early intervention years. And they get to school and they want to try to keep up the same amount, but now there's school demands and parents are trying to get back to work. And then suddenly the whole factor of time becomes, it's a variable now that has to be movable. It can't just be, we've got endless time to be able to do all of these things. I feel like you talk about this really nicely in the paper, Dave, with your case studies. You've got William, the 12-year-old, asking, why do I have to go to therapy anyway over summer? Fair question. And then you have Mac, the infant, with scattered specialist appointments. Let's just talk through each of these at the moment, because I think what really highlighted to me in your paper was just the invisible aspect of some of the things we're talking about when it comes to time. So when it comes to William, the 12-year-old who wants to go and do summer holiday things, what are some of the considerations there when we're talking about time?
Well, I have to credit my two co-authors with the way that those cases are conceptualized. You know, for concepts and things like that, Nathan Rosenberg is incredible, but the smartest person on the face of the earth is Paige Church, and you guys know her. Yes. And if anything sounds very elegant and eloquent, it was probably written by her. She's just like she just did an incredible job of just like whatever she did to get that stuff on paper. So obviously, you know, Paige is a developmental pediatrician and neonatal intensivist or pediatric intensivist, one of those things. Something intense.
Physiatrist.
And she comes at it from a slightly different perspective, but it resonates the same with her. So like if you think about any of these kids, so first, I guess more the second case would apply to like her world. Like she'll talk to some parent about a kid who's in the ICU and like what are all the things that are going to happen now. And it sounds so overwhelming. And then they had all these ideas of things that they were going to do with their new child, and they have to reconcile those now. And so like, are you putting too much of a burden on them? They can't now do all of those other things that they wanted to do. So that's one way about it. The biggest thing that I think people should take away from that case you're referring to, the case of William, which is obviously a pseudonym, is like you don't know what the kid wants to do unless you ask. The first time I meet someone new, I say, what do you like to do for fun, right? Or I'd like go back to an F word thing. If someone's coming back, say, what do you plan on doing this summer? And you can just learn a lot of information. I mean, like I'm an orthopedic surgeon, genuinely don't have enough time with each patient. It's like a nice little plug right there. But you can find out a lot of pointed information about how people are spending their time with just a simple question. So William says, oh man, you know, like I want to do this or whatever, and gotta instead go get surgery. That sucks. Yeah, well, surgery can usually wait. Go have your fun. We'll do surgery after. You know, like there's ways you can change it so that you don't have to interfere with people's time.
Yeah.
And it's bringing attention to that is like asking the right questions and like you said, what's important to them, which I think we're all doing more and more thanks to the F words and things that are highlighted in the way we question and when we meet families.
It is, isn't it? And I think if you're going to offer something, I think this is where it comes back to, the paper that we had written, David, as well. Like if you're going to offer something, you want to know that if it's going to take that amount of time and there's an exchange. Just say for William, let's just say that it's probably the only time he can have surgery. Maybe he's going through a public system. It's the only opening for an orthopedic surgeon to do it, unless otherwise he'd have to wait X amount of time. If you know it's really going to work for him and you're confident about that, I mean, surgery, but you're confident about that, but you know that this could lead to all these things that would be of benefit to him, that becomes a more constructive argument. But from our world, from a therapy perspective, is what we're going to offer actually going to be something that enhances his life in such a meaningful way as opposed to what we're taking him away from? And I think that opportunity cost all comes into it as well, doesn't it? When it comes to F words, it's always an exchange.
Absolutely. Now, David, I love how you go.
I was going to say that's the whole point of having outcomes-based research. So there's two things to say about this.
Yeah, okay.
Number one, if you're listening to this podcast, it's called Research Works. So either you mistyped something while you were searching for some other podcast, or you actually genuinely care about people who are trying to understand the way that the world works and the way that we can make things better, right? So the first thing is, yes, interventions that have not been proven and in fact are based on anecdote or something that someone said might work, don't waste your frigging time, right? Let someone at least show you that it works and then invest your time.
Yeah.
You only have 24 hours.
That's right.
Do something that works.
Yeah.
So that's number one. I don't remember what number two is because now I got hot and heavy there with that whole other thing.
Another Seinfeld episode.
I'll try to remember what it is.
Yep.
Dana, push the strings, man.
Okay.
What was the other thing? I'll think of it.
You can jump in at any point with number two.
This is about you more than anything else. Yeah.
We love frameworks, and we love how you make this really practical for us with a framework.
I love a good framework.
It just brings it all together.
It
nice
does.
tables, concise. It's something practical we can use. So you propose a practical 5-part framework for considering time toxicity with 5 different headings, and I'd love you to now step through this with you and what it means and some examples. So should we start with utility of time saved?
Utility of time
my favorite one.
Oh, okay.
It's the best one. Like you just said, right? What do you, all right. So the best example of this I have is my partner, Dom Twassen. He's a pediatric spine surgeon. And this thing happens sometimes where a kid is sick, case cancels. You were going to dedicate your whole day to doing this single surgery and now it's canceled. He calls that found time.
Yes.
So I like the concept of found time.
Yes.
I was planning to do an intensive therapy this summer, but my therapist said, you know what, if you just swim and ride your bike with your friends, that's more meaningful. So the utility of saving that time is that you get to now socialize and do other things. It also applies to your family, right? The people who are driving you around.
Yeah.
The other people who have to shoulder the burden. Maybe there was a vacation that you could do now with everybody. Yeah. So there's a lot of financial implications. Boy, you want to talk about therapies that aren't proven? Think about the financial burden of those things, and now what that enables you to do with the time you save by not doing them and the money you save. Holy moly, you can go to Australia and sit in the studio with Ed and learn about the Princess Bride.
But it's so true though, isn't it?
That.
Because some of the non-evidence-based therapies as well, it's more than 1 hour, multiple hours, multiple days, big chunks of money.
Yeah.
But like you said, the loss of time, and families are sometimes traveling for different interventions as well. And, instead of going on holidays, they're, going to do intensive therapy programs. And obviously that's a choice for each family to make. But it's up to each family to say whether that's something they...
And the responsibility of the people providing it to go, is this going to be worthwhile? And what are my outcomes I'm going to be able to show to you to show that this was worthwhile? I feel like we need to be accountable to that as well, don't we? But the concept of found time, I love it. It's like a meeting that's just been cancelled. You're like, oh, that was 2 hours. I've got time to do this now.
what a
amazing.
dopamine hit a canceled meeting is. Oh, man.
Isn't it? And you can only imagine what that would be like for a child that now gets to do something else, you know, when it was an exchange concept. I love that. Okay, utility of time saved.
Love that. Now we've got individuality of time.
Yeah, we touched on this a little bit. You know, everybody values their time in different ways. People want to spend their day doing different things. There's I like to think of it like there's circadian rhythms, like what you do in your day. Then there's these like ultradian rhythms, what you do in the course of an hour. I like to think that in the course of an hour, we spend our time different ways. We're hyper-focused, we're relaxed. I mean, like you're giving people the chance to live in their world and do whatever they want to do by not telling them what they have to do.
Sure.
Like in other words, in order to understand how people want to spend their time, you have to explore how they want to spend it and understand that not everyone's the same.
Yeah.
Like I just assume not everybody wants to like move into a rehab hospital, or not everybody wants to, I don't know. I think whatever that doesn't seem too cool, but some people really do.
Yeah.
So it is an individual thing.
Absolutely.
Yeah.
Absolutely. And I find that with lots of the families we talk to, I'm sure you do as well, David, is we've got some families who want to come for therapy in school holidays because in the term, that's their focus time. They don't want their child to miss school. They want their kid to be able to do extracurricular activities, and they almost have a break from most therapy unless it might be school-based therapies. And then they come to us in holidays. And then we have other families who are like, no way, we are not coming in holidays. That's our family time. And it's a time when our child has no, and this is absolutely essential, appointments.
Yep.
So it's really up to each family, and that's how we respond to it because they're the ones making the choices. So
that's right.
Yeah, and it's really varied. Everyone will have a different opinion.
I like that.
Yes.
Next one, I liked this one as well, downstream time impact.
I like all of them.
Yeah.
But yeah, okay, yeah.
Yeah. So the downstream, there's a couple of ways to look at the downstream impact. You can look at it like a disability identity, right? Like if you're not constantly touching the healthcare system, then perhaps you are just another kid, right? Like you're not defined by the fact that you're always in the hospital or something like that. A nice way to think about that is in orthopedic surgery, we had what was called, I think Mercer Rang called it the birthday syndrome. You know, a kid comes in, he's got like Aquinas.
Yeah.
You do gastrocs or whatever, then he's fine. And then he comes in the next year on his birthday and he has hamstrings, and like you just work your way up and down. And then they spend all this time rehabbing, all this time in the hospital, all this time recovering and having pain interference and all these things. And like in the end, that's very deleterious to a healthy social development. So then we consolidate our time and we do a single event. We do everything and their outcomes are better. Socially, they're better.
Yeah.
Psychologically, they're most likely better. You know, so like these things are all ways that you can have downstream effects. The other thing would be family, and the people who are responsible for them are also feeling the effects, positive or negative, of having all this time either saved or required.
That's a beautiful consideration. Really like that one.
Now the next one, education.
I don't remember what we were talking about with this one. What was education? Time education. Was that was more like finding
F-words.
Education of providers in cerebral palsy. Yeah, around the F words.
And complex.
Oh,
and
yes.
developmental
Yeah.
care.
Yeah. So, you know, kind of like what we were saying, you gotta ask. If you don't ask and you don't think in the framework, you're never going to find out the information. So it's so easy. Like, I'll give you another great example. There was a paper that came out a couple of years ago. It showed for CP, it was cost effective if you do Botox in the upper limb and you get a really good effect, stop doing Botox, just do surgery and move on with your life. Such a great paper. Because some people just like every 3 months go back, sit there, spend a whole day getting shot up because, you know, like it's many different little injections with an ultrasound machine. You got to sit there still.
It's a big day.
And it's like it's cost effective, which means that it's toxic to the finances, but it's also time effective to do that. Just like move on.
Yeah.
Fix the problem, take it off your worry list.
Yeah.
So educating someone to understand maybe that person doesn't really want to get Botox every 3 months. Maybe they just want to move on. Like that would be a nice way.
Yeah. And just be given the option. Again, it's just informed decision making, isn't it? It's really what it comes down to.
Absolutely. And the last one, research.
Yes. So this is like Paige's big thing, because Nathan too. But the idea that the way I just said, there was a paper that showed that finances are more efficient if you just like move on, have surgery and be done. Like no one's done that for time. So we can think of every intervention, every comparative effectiveness study you've ever looked at, and I can guarantee there's no like time variable looked at. So it could be frequency, dosage, time spent in transit, time spent not playing video games, like whatever it is. I mean, these things are not considered.
Yeah. That is such an interesting point. I love this one so much. We actually, you'll hopefully be a little bit impressed by this. When we first spoke and you had mentioned the idea of time toxicity, in one of the studies that we did last year, which is a single case experimental design, we had 4 participants and we had developed the intervention with the families at something that they thought was going to be useful for them, that they could manage. And it was 3 times a week over 4 weeks, and each session was 2 hours long. And they felt like it was worth their time. It was using our 0G robotic system. And we wanted to figure out whether coming during that time with big breaks in between. So they came 3 times throughout the year, but it was separated by like 2 to 3 months at a time. And we wanted to see whether what they had gained from the intervention actually lasted, which meant they didn't need any other additional therapy. And what the families kept record of as well was they just had a very quick survey they filled out each week about how many other therapies they did, just to get an idea about how much they're actually engaging with the health system. So as they're doing this intervention, interestingly, and we're going to be publishing this soon, but interestingly, if the kids who didn't do as much other therapy, they actually did really, really well because they were able to integrate a lot of their new skills into daily life. And they only really needed to come for these small bursts of, let's call it intensive, but Brian Hall called it distributed practice, I would say, and that's more accurate in that it was only 3 times a week.
I never heard that term
weeks.
before.
Yeah, it's a really good term. It's not, because I think intensive therapy is often hours upon hours. It's 5 hours a day, 5 days a week. That's what it's been often used with, like particularly on
Plus
social
room and
media.
board.
Right. So yeah, that's right. Whereas he's more saying that you're not in it all the time. You're actually getting a focused period of practice, but you're getting a lot of practice at home as well because you're thinking about your interventions, i.e. motor learning, contemporary motor learning. So it's really interesting, right? So within research, when we put this concept of looking at time into as a variable, it was really powerful because families were able to really talk about what was useful for them. And we could actually look at the time when they didn't have any therapy. Did they make improvements? And it was so reassuring for so many of them to go, hey, I can take 3 months off. We were taking outcome measures for them as well, and we can still maintain, if not improve on where we are as well. So like time, it's so powerful.
I love that.
Isn't
Good
it
for
cool?
you guys. I can't wait till that gets published.
Waking on.
I would say take it a step further.
Yes.
And then see what they did with their found time.
That would be good. I can't go back in time to do
And no
that one.
matter
We'll
what
go
it
forward.
is,
Yes.
it's great, right?
Yes.
Just the idea that they had outcomes that were excellent and they had found time that you can quantify.
right.
So that's Nathan's big thing. Nathan's like,
Okay.
hey, I want everybody to redo all their research
Yes.
and figure out how much time everything took. And then I want to be able to sit in clinic and look someone in the eye and say, you are going to do this thing for 97 hours in the next whatever, so that you could, like, I don't know, take 12 extra steps or whatever, like whatever it is, right?
Yeah.
And just tell them exactly what the time is and then see if they decide it's worth it or not. I mean, it's like a pie in the sky idea he has. But it's kind of realistic,
why
like what you're
not?
doing. That's
Yeah.
literally that.
Yeah, we just needed another
Because you're
element
even
to
not
understand
factoring in, you're not factoring in transit time. You're not factoring in like all the time stressing about how you're going to get there.
Yeah.
Like all these little things that we don't think about because we assign.
Yeah, that's right.
Yeah.
Yep. Being on the other side of it.
So many things.
I love that study. Nice.
David, we've got lots of things to ask you, but what I would love to, something really pinpointed that we can take home. How can we, as whether we're clinicians, therapists, neurologists, orthopedic surgeons, how can we practically consider time toxicity within our everyday shared decision making without making families feel they're being discouraged from treatment? Because obviously we're still saying, physical therapy is important. Obviously surgery is important. Interventions and investigations for medical is important. But how do you go about those conversations?
Yeah. I had a 42-year-old woman who never had a gynecologic exam, just preventative care, which is like a whole other soapbox I could get onto.
Right. Wow.
But the reason was that nobody would take the time to like care for that woman, right?
Yeah.
So positioning, like doing the exam, dealing with all the challenges, mobility challenges, things like that. So that parent felt was time worth spending, which is true. I agree with that. But you don't know unless you ask. I think the number one takeaway that I would have for everybody is just figure out your own little buzzwords to like feel it out, but just ask people like, what's going on? Like, what do you want to do? How are you spending your time? What's going on?
Yeah.
What are you looking forward to? What are your plans? What do you do for fun? Stay within the F words. Just ask these things and just understand if there's something you could do to just give them back more of their day.
That takes me to which we'll do another episode with Hercules and colleagues about the F words lens tool. Like it's such a great one in terms of a framework to go through when you're goal setting, understand what is important for them, who's in their family, do they have any friends? Do we need to make sure we actually prioritize time making friends in terms of how the kind of interventions might look like? And I love that you keep referring back to the F words because it is such a tangible tool that we can use as a conversation piece to get to know someone. To understand what their value on time is. Like if you were to talk to me about it.
Bernard Dan added.
Yes.
Oh, sorry.
No, you go. You go. No, go. Here you go. Bernard
Dan had what I found to be a very powerful paper where he said that the other F word is freedom.
Yeah.
And you could take that to mean whatever you want, but people should have, half my practice is adults. So adults are sometimes really not free to make their own healthcare decisions and decisions about how they spend their time. But kids can be. These are all things. And we as physicians and clinicians should all be free to talk about these things and not stay within the burdensome constraints of like, you have CP, you must do this, then do this, then do this, then do this. It's okay that there's a diversity in treatment.
Yeah. And we've spoken a little bit now about clinicians, organizations thinking more about that, asking the question and looking at what time means for them. If some of our listeners here are parents, David, what will be an important piece or message for them when it comes to how they want to spend time for their kids and what can they look for? What are some questions they can ask?
Oof, man. Well, first of all, obviously, any intervention that is recommended, any test that's recommended, you're always allowed to ask, like, what's the evidence for this?
Great.
And you have to look at everything like it's going to take time out of your life, right?
Yeah.
Even just getting an x-ray versus doing some therapy or whatever. So I would say just that plus really think about what you want to do as a family. You know, do you want to be that family who like RVs through the country and goes to all the national parks and things like that? Do you want to be people who go in the water, which is a huge challenge? Like, what is the challenge that you envision or used to envision or want to envision? Like, how can we get you to do what you want to do and not maintain a situation you're in because you were told to stay in that situation? I don't know.
Yeah.
I think you dream big, you be a realist, and figure out what you can do and what you can achieve as a family. And again, coming back to the F words. I don't know. I could go anywhere with that question.
Yeah, I know. I think what resonates there so much, or things that I do see online, is there's this whole battle between there's these body structure and function physios and the participation-based physios. And it's like this battle. It's quite interesting when you watch it online. You know, the therapists are really advocating for participation. It's exactly what you're saying there, David. It's like, how can we get you out into life and live life, acknowledge there is this child does have a disability and there are things that are challenging. There's some interventions that are required, but we're trying to find a way, a mechanism, a pathway so you can live the life that you want to live. Versus you've got body structure and function, which I was once, that's how we're trained, is like, well, before you can do all of that, before you can participate, you need to have better strength. You need to have better core. I saw someone say if you improve your core muscles, then your spasticity melts away. It doesn't. Spasticity is still there. You can't change all those factors. But if you're going to wait for that to be accomplished before you can live life, I think that's what we're trying to pull away from.
You're missing out. Time you can't get back.
That's right. That's right. So you don't have to do one or the other. You can do both, but you need to be a little bit more selective about what it is that you're doing. And I think we don't have to do one.
I'm so glad you're not one of those body structure function people. It just seems like a really harsh way. Like that's a crazy, like you have to graduate medical school to be a doctor. That's fine. But like I could go rock climbing tomorrow. I don't need a rock climbing degree. Right? You could just go participate. You don't need to pass. I don't know. I'm probably simplifying it, but still like what you're saying resonates with me.
Yeah.
100%. It's such a big thing because I think families will listen to what their physical therapists or physios and, you know, orthopedic surgeons, what we say. And so they want to do the right thing. But
we've got to be thoughtful about our words.
Yeah, we've got to be thoughtful about how we do it and look at so many things you've said today, you know, with the F words, which I think we're moving in that direction. And it's the shift we've seen in the last 10 years is huge. But it's just continuing to drive this and be like, we can continue to do this better. And I think looking at time is a big way, particularly in a world where time is, you know, everyone's busier than ever because we're so connected. We have so much information, so much contact. You don't want to miss out. You want to do everything. So this is the time to talk about time.
Yeah, that's right. That's right.
Cool.
Yeah.
I have no movie comment. There was not.
I was waiting for it. I thought
I thought you were going to lead into something like that.
Sorry.
Well, I think this conversation is something
the sea was angry that day.
Oh my gosh, there he is. It's just like, yeah. Great line. Apart from the movie, the TV show references, actually, most of them are, I think this conversation is something that I hope that people will just take away and have a bit of a think for yourself. And this sounds really overly simple, but for me, my example is I'm a terrible gardener. I think I used to have more time for gardening. Back when I was younger, I planted lots of trees. I've got lots of shrubs. My garden looks amazing now, but I can't maintain my garden. And as a result, it takes way too much time for me. So for me, I now make sure that I outsource that to someone that can do it in just 2 hours rather than me take an entire weekend to do it, because how I value my time is no longer just digging holes in my garden. It's just not how I love it. But other people will just absolutely love it. So I guess it just shows it's individual. It's what you value in your time. Like I'd much rather go out and have a good meal with some friends and that fills my cup. Whereas for other people, they actually really love gardening and that fills their cup. It is so individual. So I hope that people are hearing that we're not saying one or the other. I think we need to get away from the one or the other, but it can be your choice, and autonomy is a big part of it. But we're not done just yet, David. Like, as it sounds like I'm summing up, but we're going to go to our final segment, which is our most popular segment. We've had to skip it a few times, mostly due to time constraints. But we're going to make sure we fit it in here. So here we go. Let's go into the most popular segment.
Well, now that you're not gardening, we clearly have time.
Exactly. I've got time to do this now. Let's head into Tell It to Ed. Ed is our producer. He doesn't have a background in child health, but he has been listening to this episode, probably thinking about movie lines, but also thinking about the concept of time toxicity as it has been today. So before, Ed, you have time for one question. David, I head over to you first to summarize this work in about a minute or so. And Ed, you'll have time for a question. Take it away, David.
Okay. Time is valuable our patients, their families, other doctors, everybody, every single person you pass in the street is spending time doing something. And I bet you haven't thought about it. And you haven't thought about how they got there, what barriers they faced, how it was challenging to them, how it was easy for them, how they want to spend their time, how you want to spend your time, how we all spend our time in different ways. You have to think about it, because if you just tell patients how to spend their time, that's probably not going to be 100% what they want, I guess. I don't know. Not a great elevator pitch, right?
No, just that last part you didn't have to, but the question was good. It was good. It was good.
Okay.
That was good.
I think the future of our practice should be one where we know how much time people are spending on various things, and if it's changing their natural history or lives at all.
Yeah, that's wonderful. Wonderful, wonderful summary. I love that. Ed, over to you.
Fascinating conversation. I really love this whole concept of...
There are a lot of nods. I saw lots of nods.
Of time toxicity and kind of how we need to think about that. And I think the one thing that I keep coming back to is... So I'm a big believer in the whole incentives can explain outcomes. And so my attention is about, well, families are incentivized to kind of push for more therapy because they believe it'll lead to better long-term, care and outcome for their child or their loved one. Clinicians are kind of incentivized around effectiveness, like fixing the immediate, clinical problem in front of them. And then there's the individual, the child or the adult with CP, and they might be incentivized by something very different, like whether it's just enjoying their childhood, having energy for play or relationships, or just, not having their whole life dominated by these like medical appointments and, therapy appointments. And I guess my question is just how is it navigated when their incentives don't really line up? I don't know if I'm saying that very clearly.
I get it. No, I get it totally. I think the way you navigate it is lining up the incentives, right? Like when I see an adult who's doing well and they have everything's fine, they're stable, they're good, I tell them, come back and see me in 2 to 3 years. And they freak out. Like, what's going to happen? I don't know what's going to happen. You probably went 10 years without seeing a doctor and you're still fine. So like they know they have my number. They can call me whenever they need me. But I say, go away. Like, go do something. So I'm not incentivized to do more. I'm certainly not referring them to 7 other people.
Yeah.
In fact, kind of like a geriatrician, a lot of times we go through the various people they're seeing in the health field and see if we can trim some of them down.
Yeah.
So yeah, I mean, it's like same as everything else. So in order to resolve that tension, I think you have to look at head on.
Yep.
And try to actually line those things up.
Yep.
I'm going to steal a little follow-up question here.
I said one question. Okay,
So the pod has been invited to the European Academy conferences for quite a few years now. And I think over the last few years, coming into this without a therapy background, I've kind of seen the whole focus on the lived experience, the individual into research. And it seems like everybody believes that this is how it should have been years ago. And I guess are we at that stage with the medical and health community where it hasn't kind of translated outside of that research bubble, for want of a better term, and brought into the real world where people like yourself, David, I think it seems rare. I mean, we hope that it's not, but it seems rare that someone like yourself would recommend them not to see you or not to be referred on to 7 other people.
I like to think a visit in my clinic is not a waste of time, but genuinely, like they just don't, if you don't need to see me, you just don't need to come in. There's plenty of other people to be seen. It's fine, right?
Yeah.
So I guess it is tricky in that regard. I mean, like a little kid who's fine, they'll have an appointment maybe in a year and a half, something like that. Like sometimes we have people come back to CP clinic in a year and we don't even know why. We always say that out loud too. Like, come back in a year. We're not quite sure why.
Yeah.
We think you're fine.
Yeah.
Just come for a social visit. And usually they come back and we just talk about things that are not medical at all.
And there's that connection point.
Yeah. There's definitely a lot of pressure in medicine to not have that kind of practice. But it's fun. You know, you integrate yourself in people's lives and they can understand that it's not just all about medicine,
sure.
You know, like walking into an office and getting a shot or something like that.
Yeah,
so.
Yeah.
And that's the thing.
By the way, this people talk about. Oh, I'm sorry.
No, you go.
This very easily relatable to physical therapy, but like when the concept was being developed, we weren't specifically thinking about physical therapy. We were thinking about more like complex medical stuff.
Sure.
So it's easy to say like, oh, PT, and like make them into, oh, they're going to take all my time, those dang physical therapists. But really, we're just thinking about everything in general.
Yeah, yeah.
And that's exactly there, David. That's what I was going to say is in terms of like, we're not downplaying what we do and the importance of what we do, but it's about when you do it, you don't want it to be a waste of time. You want to make sure it has an impact that probably wouldn't have happened otherwise.
That's right.
And so that's where drawing on evidence-based techniques, you know, talking to the family individually about how it's going to impact them in terms of the dosage of therapy and not just doing things because it's the way it's always been done, weekly therapy, weekly.
Good
you
point.
know, there's a purpose and a real specific dosage and plan behind that therapy.
Yeah. I think.
And look how you guys are evolving the dosage, right? You're evolving it now.
Yeah,
you're making it more. You're giving people found time. There's like a downstream impact there.
Yeah,
so it's
that's
good.
Right.
I like
just
it.
not the. I think the traditional weekly. You know.
Yeah.
Just go weekly. Why? Let's ask the questions. I love it. You've just made us ask lots of questions. So, David, thank you so much for staying up late. I know this is late for you, but late for probably me if it was my time, to speak with us about this topic. It's been so wonderful to hear your insights, the story about how it all came about. And it's going to be something that I think conceptually people will think about for a long time. I certainly have and have started to integrate it as well. But obviously there's still more to do, which is always good. We really encourage everyone to read the paper, take a look at it, share it with your colleagues. We'll pop a link for that for you so you can get access to that as well. So you can head over to our website, researchworks.academy, where you can find all of their resources. We've got courses on there now as well. Just lots of things to hopefully help you to save time if you're trying to be evidence-based. We've got everything in one place for you and it's all free. So thank you very much. Thanks, Marissa. Did you enjoy it?
I loved it. Thanks,
great.
David. Yeah. Wonderful. We could chat.
For a long time.
Good speaking to you guys.
Great to speak to you, to all of our listeners. Thank you once again. We'll talk to you all again next time. Bye.
Bye.
I'm disappointed no one went with the in case I don't see you, good afternoon, good evening, and good night from The Truman Show. What kind of millennials are you guys?
I just watched that for the first time 2 weeks ago, The Truman Show.
Really?
And I was spun out. Yeah.